Good morning, everyone. Thank you all for joining us today for this activity titled Talking Multiple Myeloma, Strategies to Treat and Manage Patients in the Frontline and Beyond. This activity is provided by the University of Cincinnati and Practice Point Communications and supported by independent educational grants from Bristol Myers Squibb and Janssen Scientific Affairs. The content development faculty are here today, including me and the esteemed Dr. Nina Shah from the University of California, San Francisco. Welcome, Nina. Thank you for joining me this morning. It's really exciting to be here. We're going to have a great morning. We're going to cover a lot of really exciting updates in multiple myeloma, and I think you're really going to enjoy the program we have. The learning objectives we have are here. So upon completion of this activity, participants should be able to review the latest guidelines for treatment and management of multiple myeloma, deliberate on the emerging standard of care for frontline therapy, evaluate the safety and efficacy of triplet and quadruplet combinations in early lines of therapy in multiple myeloma, determine goals, administration preferences, duration, endpoints to individualize frontline therapy for diverse patients with MM, and finally, discuss strategies for maintenance and further sequencing of therapy in multiple myeloma. So, with that aside, we can dive into the material. So, I'm assuming that most of everyone who's joining on this call is not a neophyte to multiple myeloma, and so I won't spend a lot of time on this, but just a primer on multiple myeloma. It's characterized by a clonal expansion of aberrant plasma cells in the bone marrow. The incidence and prevalence of multiple myeloma in the United States are interesting. In 2022, 34,470 new cases will be diagnosed, but there are an estimated 159,787 people alive with myeloma in the United States as of 2019. So right away, you can tell people are living longer with this disease. And so I think a lot of that is due to advances in frontline therapy and relapse therapy. We're not going to talk a lot about relapse therapy today, but we'll be reviewing frontline therapy today. And I think a lot of the reason we see so many people still alive with this disease is because of advances in that field. The initiation of multiple myeloma and how folks get it is still a little bit murky. We know that, in most cases, multiple myeloma is not a genetic disease and that it's not inherited from, family members. There are rare occasions where we see it pass through families, and further investigation is ongoing in those cohorts to try to determine if there are genetic predispositions or genes that are mutated, similar to that like we see with breast cancer and the BRCA mutations that could predispose to multiple myeloma. But for the most part, it's a stochastic idiopathic event. How does it start? The triggers are sort of unclear. I think one thing that we know about multiple myeloma for sure is that everyone who's had multiple myeloma has a precursor diagnosis called MGUS. MGUS is monoclonal gammopathy of undetermined significance. And what that is it's a clone of plasma cells. And as everyone knows, that's one of the hallmarks of cancer is clones. And so any clone that we have, if we discover a clone, whether, it's a B cell clone or a plasma cell clone, that would be considered to be abnormal. And so what starts with a plasma cell clone over time eventually turns into smoldering multiple myeloma and then to active multiple myeloma. And it's due to competing, what happens over time is we develop additional clones and these clones compete. And there's also interactions with your regular immune system and within the bone marrow microenvironment. And all of these together can lead to development of multiple myeloma. So our first polling question is shown here. Which of the following is or are responsible for progression of smoldering multiple myeloma to active multiple myeloma? And we covered this a little bit on the slide before. So A, competition between initiating clones. B, selection pressure within the bone marrow microenvironment. C, both A and B. Or D, none of the above. Okay, perfect. So for those of you who chose C, both A and B, that is in fact the correct answer. So this is a little bit of an expansion on the topic we were discussing earlier, but the pathogenesis of multiple myeloma as it starts with MGUS to smoldering, a lot of that has to do with dissemination of disease. So one thing we know about multiple myeloma is at the time of diagnosis, it is a disseminated disease. It is a disease where local therapy, like we might use for early stage breast cancer, early stage colorectal cancer, is not effective, with the exception of solitary plasmacytomas. But even in solitary plasmacytomas, which would be defined as a single site of disease with no other evidence of disease to a large extent, even those patients almost inevitably all develop multiple myeloma. So I think there's good evidence there that this is disseminated from the start. And a lot of what drives that, we think, is circulating tumor cells. And so these are largely responsible for why the disease is disseminated at the time of diagnosis. This is the idea that you have plasma cells that start in the bone marrow, but then get into the blood. Many patients with smoldering or even MGUS may have detection of circulating plasma cells at the time of diagnosis, which may turn out to be an important prognostic factor in the future for development of multiple myeloma. The natural history of multiple myeloma is shown here. So as we've discussed a couple of times previously, multiple myeloma almost always starts with MGUS or smoldering multiple myeloma, which is basically, again, the presence of a clonal plasma cell disorder, but without evidence of the end organ damage that we see with multiple myeloma or any of the disease biomarkers that are associated with that. So over time, that does progress, the tumor volume increases, and at some point, patients develop multiple myeloma. They would then receive first-line therapy. The disease is then treated into remission, and then over time, though, patients always relapse, almost always, and subsequent relapses always are preceded by shorter and shorter durations of remission. And so, in many ways, multiple myeloma is almost like, treating metastatic disease for a solid tumor at the time of diagnosis. Achieving a cure is difficult. The whether or not patients can be cured is still something that is debated amongst folks in the field. But I think for most patients, at least when I'm meeting patients in clinic, I think I tell people it's largely incurable, though one can find examples of patients with very long remissions. So another important fact, and a lot of this has to do with the disease biology, but also the treatments, is that fewer patients with multiple myeloma reach later lines of therapy. And these data is a lot of what's driven us to utilize effective therapies earlier rather than later. So, I think one common pitfall I've seen is, well, let's save this drug for later. When I'm talking to community oncologists, we have, we have 3 different combinations. One might include more drugs. I think a pitfall is, well, this drug works, why don't we use it later? Well, the problem is many patients don't make it till later. And so there's these interesting data that were published a few years ago looking at the dropout after each line of therapy in terms of the patients that don't survive. And so what you can see here is after the first line, 34% of patients drop out, then 23% after second line, then 23% after third line, and so on. And so you get the point that, patients, may not survive because of the disease complications. So why should we sort of, hold on to these treatments until, a patient can't get them? So I think that drives a lot of, what we're seeing with study design in at least at present. The goals of therapy in multiple myeloma are not only to improve quality of life, because that's really the main reason for this, because we can't cure it. And so all treatment is meant to try to control the disease and to help people live longer. But also to, one important concept in multiple myeloma that we know is that getting the deepest response possible is often associated with the best outcomes, not always, but for the most part. And so you'll hear experts talk about MRD, minimal residual disease. And what this is really looking at when we have a patient with no evidence of disease by the standard markers like protein electrophoresis, immunofixation, flow cytometry of the bone marrow, looking with more sensitive techniques like next generation sequencing of the immunoglobulin receptor, for example, which is one of the more popular platforms for assessment of MRD, can be useful for really looking at a much deeper level 1 out of a million cancer cells for the presence of residual disease. And we know that patients who achieve that level of absence of disease tend to do much better, have longer survival. And so this, what this slide basically shows here is you see these curves, the deeper the responses, in general, this is not always true, but for the most part, the longer the time we will have until the patient progresses. And so along with that goes quality of life, because we know one of the major drivers of why folks have poor quality of life of multiple myeloma is not just the treatment, but it's also the disease. And the disease is always an 100% guaranteed outcome if we don't treat it appropriately. But also long-term survival, and survival has improved dramatically in multiple myeloma over the past 20 years. So our next polling question is shown here. Which of the following cell types is responsible for dissemination of extramedullary disease in multiple myeloma? So A, cancer stem cells, B, normal plasma cells, C, natural killer cells, or D, circulating tumor cells. Okay, terrific. For those of you who chose circulating tumor cells, that is the correct answer. So very good. All right, well, I'm going to hand it off to Dr. Shah. Dr. Shah, why don't you take it away? Thank you.
Thanks so much. So we're going to talk a little bit right now about the therapy of newly diagnosed multiple myeloma and look at specifically guideline recommendations. So we think about a patient with newly diagnosed myeloma. This is evolving even as we speak. We think about the current approach. So we've got newly diagnosed myeloma, and what we have is risk stratified patients. So things that we would consider in risk stratification, or factors that we would consider also in choosing their therapy, would be if they're transplant eligible or not, thinking about age, performance status, comorbidities, which you can get on various scoring indices of frailty as well as organ function. And with all this in mind, you can determine whether you think your patient is transplant eligible or transplant ineligible. And again, this is autologous stem cell transplant. So looking to think about what you would do for these people who have newly diagnosed multiple myeloma, you have in the back of your mind, of course, the issue of transplant eligibility, but you also have at your disposal different drugs with different categories. And sort of our main drug categories are seen here. You have the proteasome inhibitors, including bortezomib, carfilzomib, ixazomib, the immunomodulatory agents. And I would say of those, for newly diagnosed, lenalidomide is the most common. Alkylators, including melphalan, which is what we use for transplant, cyclophosphamide as well. There's other conventional chemotherapies you may use if they have very aggressive presentation. And then now we have the monoclonal antibodies, at least one of which is approved in the Frontline, which is daratumumab, but isatuximab is similarly an antibody against CD38. So we have a lot of potential options as far as categories of drugs. And we as myeloma doctors love to put these together as a sort of alphabet soup, but it's worth it to go over what exactly we have for the therapy of transplant eligible myeloma, newly diagnosed, based on the NCCN guidelines. So the preferred regimen as of now, with a category 1 recommendation, is bortezomib, lenalidomide, dexamethasone, affectionately known as VRD, but there are other recommended options. So these would be categories 2B, which would be KRD, carfilzomib, len-dex, or daratumumab, len-bortezomib, dex, that's DVRD, a quad regimen, and then ixal-len-dex, which would be a 2B recommendation as well. And then sometimes you may use certain circumstances, bortezomib, thal-dex, BTD, category 1. And again, that might be in a situation where you don't have access to something like lenalidomide, which is true, for example, with other practicing areas, like, for example, Europe. But I would say that thus far, and we're seeing a shift, as I'll show you in data, that VRD with the category 1 and then now DARA VRD category 2B are sort of the most popular as we go on. So what category recommendation does the DARA bortezomib len-dex or DARA VRD regimen have in the latest NCCN guidelines? Category 1, category 2, category 2B, or none of the above? Okay, great. All right, so good. 2B, they've been wavering there, but yes, that would be it. Okay, great. Moving on to our next topic, we want to talk about updates in transplant-eligible newly diagnosed multiple myeloma and what the efficacy is of triplet combinations. So if you go across the board for patients with multiple myeloma, newly diagnosed, you can see that there are many trials that have looked at this, also considering transplant versus non-transplant, and also looking at quads versus triplets. And this is not meant to make your head spin, but rather to show that with these randomized controlled trials, we've been able to answer some key questions. So in the first trial, the IFM is early versus late transplant in the context of RVD therapy, and this was shown to improve PFS, but not overall survival. In the FORTE trial, KRD transplant versus KRD, here again, transplant was shown to improve progression-free survival as well. In the CASSIOPEIA trial, this was a combination of quadruplets versus triplets. And here, Dara-VTD was compared with VTD. This also improved progression-free survival, although the medians have not been reached yet. And then in the GRIFFIN trial, which is a phase 2 randomized control trial of Dara-VRD versus VRD, that's more a US-based trial, that also is trending towards improving progression-free survival, although it hasn't quite met there yet, but certainly it has met its primary endpoint of showing increased stringent CR percentage at the end of consolidation before maintenance. So that's why that's considered a positive trial. And then, of course, we have determination RVD transplant versus RVD, the American version of the early versus late transplant. This was just presented this past year at the ASCO, this past month at ASCO, and this really showed a nice improvement in PFS of 21 months difference, although no change in overall survival as of yet. So we have these pieces of data that help us to inform what is the best thing to do for our patients. So if you look at the IFM DFCI 2009 trial. Now, this is both trial designs, but this is the European version. You can see that patients with newly diagnosed multiple myeloma were randomized to get RVD versus RVD with early transplant. So all patients had RVD induction. All the patients underwent cyclophosphamide-based mobilization. But then in the early transplant group, those patients went on to transplant and then consolidation for 2 cycles, subsequently maintenance, versus the patients in the late transplant group had a total of 8 cycles of RVD and thereafter went on to maintenance therapy. And I will point out here that the maintenance therapy in the European version was limited to 12 months. So as you can see here, the progression-free survival endpoint, which was the primary endpoint, was met. And RVD with early transplant had a PFS of 47.3 months, which was significantly higher than RVD alone of 35 months. However, overall survival difference was not achieved here. Those two curves look essentially superimposable. Now, of course, this is early versus late transplant because the plan for this clinical trial was that patients in the non-transplant arm or non-early arm would go on to transplant once they did progress. Not all of them did, but so I don't want to say it's transplant versus no transplant. It's more transplant early versus transplant late. And with this, we've been able to inform our patients how you're going to do potentially if you get an early transplant. But I think what is important, and Andrew touched on this a little bit, is that we're really trying to understand how much depth of response matters. And what you can see here, if we use MRD to look at these responses, for patients that had MRD negativity, whether they got there by transplant or not, which is the solid line and the solid purple line and the dotted purple line, those patients did way better than the patients who had MRD positivity before their maintenance therapy, whether they got there with transplant or non-transplant, suggesting that the depth of response is really a way for us to predict how people will do. But how do you get to that prediction? Because remember, these people were already pre-assigned. And if you look on the right-hand side, you can see patients who had transplant were more likely to get to MRD negativity, suggesting again that this additional tool of high-dose melphalan is a way to get a deeper, cleaner response. So now we look at the determination study, which is essentially similar trial design with one key difference, I would say. So for patients with newly diagnosed myeloma, as I already showed with IFM, they were randomized in Arm A to receive RVD alone, then cycles 2 and 3, stem cell collection, and then finished up for cycles 4 through 8, and then went on to R maintenance, but this was indefinite maintenance. And in Arm B, the early transplant arm, the patients received RVD cycles 2 and 3, and then stem cell collection, and then had melphalan transplant, and then went on to RVD for 2 more cycles, and then len maintenance therapy, again, indefinitely. So what is important here is that we practice this more consistently in the US, that patients will get RVD and then get indefinite maintenance, transplant and then indefinite maintenance. And I think this is really reflective of what we've done. And even prior to the study, that these results that were presented, we had seen from previous data from various clinical trials, but also retrospective data, that patients with indefinite maintenance do better. More is better and longer is better. And of course, that makes sense considering, as you already heard, that myeloma is an incurable disease. So this was a key difference between what we saw in the IFM versus the DFCI, and I think explains some of these results. As you can see here, the determination results show that the PFS is significantly better for the patients who underwent early transplant with a PFS of 65.7 months versus 41.9 months. And so there's a clear 21-month difference between the patients who are actually getting early transplant versus late. Now, what good thing about this, and I guess the good thing is all patients are doing well, right, no matter what. This is much better than the data that we used to have with myeloma. But on the right-hand side, you can see that as of now, with a median follow-up of over 70 months, you can see that the median overall survival is not different. Now, people can say whether this is the thing to judge it on or not, and there are different ways to interpret this data. But essentially, right now, what we can tell people is that if they want to stay in their remission, the first remission the longest, then you would consider doing an early transplant. But that might not change how long a patient would live overall. Although I would say that we do have to wait for the median overall survivals to read out in both arms before making that determination, no pun intended, definitively. So how do we see how these patients are doing for depth of response? Now, again, as we pointed out with the IFM study, getting that dose of melphalan seems to make things a little better for patients. And certainly if you look at the CRs, it looks like patients are more likely to get into a CR with the transplant versus no. But really what we would like to see by MRD status is what is shown on the right-hand side. So getting to MRD negativity is the way to go. So if you go into MRD negativity before that maintenance, you definitely have an improved chance of PFS. Now, how do you get there? It seems that you might be getting there the best potentially by getting the transplant. But if you don't get to MRD negativity, which is the RVD transplant arm, which is the purple, versus getting their RVD alone, certainly, again, you do better having gotten the transplant. So I think any way you slice it, you can probably say that the transplant is given the chance will give you a higher chance of PFS, no matter if you get there to MRD negativity or not. It's probably the best way to ensure that you're going to get to MRD negativity. But again, there is no difference as of yet in overall survival. So this definitely means you have to talk to your patient clearly about this data. And it's sometimes hard to interpret. So it's good to sort of have these ideas in mind about length of time, differences in PFS, but being clear that this may not change how many total months this person may live with this disease. Now, the FORTE trial is another trial that looks at early versus, well, this is actually more transplant versus non. This was a 3-arm trial, but I really want to focus on the arm B and C because I think that's the most informative. Here you can see for arm B versus C, patients were randomized as newly diagnosed patients to get KRD for 4 cycles. All of patients went to mobilization, and then patients in arm B went onto a transplant versus arm C, patients got another 4 cycles of KRD, and then both arm B and C got another 4 cycles of consolidation KRD, which means that in arm B, it was KRD 4 transplant, KRD 4 versus in arm C, KRD for 12 cycles. Thereafter, there was a second randomization to R versus KR maintenance, although the first endpoint was really looking at PFS at the end of the transplant before going on to the second randomization. So let's see what happened from the first randomization. As you can tell here, the PFS from the first randomization shows that getting transplant with KRD is the more superior option here. And I really like to compare, in my mind, that green versus dark purple or dark blue line, because that really shows us what the addition of transplant is. And even with these novel regimens, so I'm very happy that this has a novel regimen approach, you can see that the transplant did add something. Now, if we look at what happens here, and this is always a question, do we give more in maintenance? And this is the toss-up in opinion, because there's always things that you can do to make things better as far as outcome, but there's also this issue of quality of life that you have to think about because people are on doublet maintenance. It is something they have to come over to the clinic and get. And you can see here, again, PFS from second randomization, more is better. KR, which is the top curve, did better than R. suggesting that doing more for your patients is better. And I'll point out that this is something that we've thought about in our high-risk patients as well. Now, if you think about MRD negativity, if you look again, comparing that arm B versus arm C, KRD transplant versus KRD 12, you can really see that patients are getting into MRD negativity, maybe a little bit higher in the KRD transplant arm versus the KRD alone. And if you look at sustained MRD negativity, which I think is going to be a really important endpoint for us as myeloma doctors, you can see that those patients are getting there better with the transplant arm versus not. So based on the data from the IFM, DFCI, Determination, and FORTE trials, which of the following is true? Triplet regimens with transplant lead to better outcomes in newly diagnosed myeloma. Triplet regimens alone without transplant are more efficacious in newly diagnosed myeloma, or transplant has no role in newly diagnosed myeloma, or none of the above. Please vote. All right, for those of you who said that triplet regimens with transplant lead to better outcomes, I would agree with that, because we know that in all of the studies, they have had improved progression-free survival with this particular regimen. Okay, with that, I think I'm going to switch it over to Dr. Cowan for updates in transplant-eligible newly diagnosed multiple myeloma.
Thanks very much, Dr. Shah. I'm going to be diving into the data on quadruplet regimens for transplant-eligible newly diagnosed multiple myeloma. And to start, we are going to start with a study, one of the first studies that read out that really showed a benefit of quadruplet regimens, the CASSIOPEIA trial. And so what are we talking about when we're talking about quadruplets? I mean, we're talking about 4 drugs, right? But for the most part, we're talking about proteasome inhibitor, immunomodulatory agent, dexamethasone, plus a CD38 antibody. And so when we're talking about quads, that's largely kind of what that nomenclature refers to. So the CASSIOPEIA study compared daratumumab plus the standard backbone in Europe for newly diagnosed multiple myeloma, which is bortezomib, thalidomide, and dexamethasone. Note that thalidomide is really not used in the United States anymore, but is largely used in EU and actually in most other countries in the world for newly diagnosed myeloma. So that's why VTD is used here. So just something to think about when you're interpreting the results of the study. This was conducted in transplant-eligible multiple myeloma patients under the age of 65, I believe. They had 111 sites, and it was from 2015 through 2017. And so on the study, patients received 4 cycles of either DARA, VTD, or VTD, followed by autologous stem cell transplant, followed by 2 cycles of consolidation with DARA, VTD, or VTD. And so the first randomization there was to DARA, VTD, or VTD. There was a second randomization, which I think a really nice design of the study, for maintenance. And so for patients who had a partial response or better, they were randomized to either daratumumab maintenance, which was given every 8 weeks until progression for a maximum of 2 years, or observation. And so just note that comparator arm of observation is not really, I think, something we would do in the United States, as Dr. Shah was mentioning. The standard is really indefinite len maintenance. And so that's just something to think about when you're interpreting the results of the study. We're going to be focusing most, though, with this study on the results of the first randomization. So the outcomes are shown here. And so what we see here is a bar plot that shows response rates that are color-coded at the following time points after induction, after transplant, 100 days after transplant, and then the best response. And on the left is DARA VTD, on the right is VTD. And so I think, a picture tells 1,000 words. And I think, what's very clear here is that with DARA VTD, we see a higher proportion of that bar graph filled with patients who've had a stringent complete response, 43% versus 33%. Remember, a stringent complete response means no evidence of myeloma and normalization of the free light chain. So that's one of our best, beyond that, we would be talking about MRD, which we have a slide in here later. But, what this tells us is we get deeper responses routinely with the addition of daratumumab. And that benefit, if you see on the right, seems to hold across multiple subgroups, with the exception of the high-risk patients. Shown here are the Kaplan-Meier curves for progression-free survival. On the left, DARA VTD versus VTD, and so there's an obvious obvious benefit here for Dara-VTD. And then on the right, we see the curves stratified by whether patients did or did not achieve a stringent CR. And so I think that theme that, the getting to the deepest response possible is important, but does it really matter how you get there? And that's a topic of, everything is eternally debated in multiple myeloma, whether it's bisphosphonates or antiviral prophylaxis. But, this is another thing that's debated is like, does it matter how we get there? Is an MRD negative response from KRD equivalent to an MRD negative response from KRD plus transplant? Many would argue the transplant adds something. But I think there are data that suggests that getting to MRD negativity is what's most important. So, and this graph largely reflects that. MRD negativity, again, I feel like this is going to become something I repeat a lot over this slide, is shown here. And so what we see here are the Kaplan-Meier curves for MRD negative amongst the patients who achieved the CR, which is really where, according to the IMW, we should, be assessing MRD negativity. For patients who were treated with Dara-VTD, the progression-free survival is excellent, slightly less so for VTD, which again, I think argues again that the addition of Dara may provide benefit even, amongst the patients who've achieved MRD negativity. And then you can see there that both Dara-VTD and VTD patients who were MRD positive did worse. And so I think this again drives home the point of how important MRD negativity is. So our next polling question: in the CASSIOPEIA trial, the addition of which one of the following agents to VTD was associated with improved PFS? A, carfilzomib, B, daratumumab, C, isatuximab, or D, elotuzumab. So go ahead, everyone, and make your choices. Excellent. Well, for those who chose daratumumab, that is the correct answer. All right. So the next study that I'm going to review is the GRIFFIN trial. So this was the US counterpart for the CASSIOPEIA study. Although I would note that the CASSIOPEIA study was a randomized phase 3 study, the GRIFFIN trial was a randomized phase 2 trial. So some difference in terms of the statistical design of the study. But a similar question being asked is, if we add daratumumab to the standard of care, which at the time was RVD, can we improve the depth of response? And so the primary endpoint of the study was, in fact, the percentage of stringent complete responses. So this study was designed for patients who were transplant eligible. It was a 1-to-1 randomization of Dara-RVD versus VRD. Patients received 4 cycles. All patients underwent autologous stem cell transplant. For consolidation, patients received 2 cycles of Dara-RVD versus RVD. And one question that commonly comes up is, what's the deal with consolidation? And that's, that is something that's designed in a lot of these studies. I think in most practices and most people who treat multiple myeloma, there are not many who use consolidation on a routine practice. And so I think it can sometimes be confusing. But what I would really focus on here is really the treatment before the transplant. And a lot of us will front load the treatment before the transplant rather than giving consolidation after the transplant. So nevertheless, in maintenance, patients received either daratumumab plus lenalidomide or lenalidomide alone. The lenalidomide was given indefinitely. Daratumumab was given for 2 years. And so the outcomes are shown here. The GRIFFIN trial, Dara-RVD, as we might have come to expect from the results of the CASSIOPEIA study, had a higher percentage of patients who achieved a stringent CR post consolidation, 42% versus 32%. Amongst evaluable patients, MRD negativity rates were also much higher, which I think also follows from the results of the CASSIOPEIA study, 51% MRD negative versus 20% MRD negative with RVD. So right away, we're seeing a trend towards deeper responses, higher rates of MRD negativity. What about survival and progression-free survival. So to date, the study has not shown a benefit in a published benefit in progression-free survival. 12 months PFS, RVD versus RVD are largely the same. 24 months, we're starting to see a slight separation of the curve, 95.8% versus 89.8%. If you had to ask me, based on the results of many other studies, where we see improvements in MRD negativity, I would suspect, and feel free to call me on this later if I'm wrong, I would suspect we will eventually see an improvement in PFS. MRD is a very strong predictor for survival and progression-free survival, but just to be clear, we don't have data for that's published yet. So hopefully we'll see more data in the coming years that looks at these long-term outcomes. Overall survival, also very similar, but again, I think that it's important to note that this is pretty short follow-up so far. So, I think a lot of the times we see these survival benefits emerge much later, like we did with KRD versus RD in the ASPIRE trial. Or ASCENT trial, rather. So outcomes after maintenance are shown here. So DARA, remember the comparator arm, lenalidomide maintenance versus DARA plus len, 24-month PFS rate, 91% versus 89%. And again, we're starting to see, at least in these data, not a statistically significant PFS benefit, but a trend towards improved PFS in the DARA RVD group. So I think these data are very promising. And I think that's a reason a lot of I think across the country, we're seeing increased adoption of DARA RVD in the frontline setting, not just for high-risk patients, but for all patients. Another piece of data that I think are really important with respect to quad and inclusion of CD38 antibodies in the frontline setting is the GMMG HD7 study. This was a study that was conducted in Europe. These data were published last year. This was patients who had newly diagnosed multiple myeloma and were transplant eligible. Patients received induction with isatuximab, which is another CD38 monoclonal antibody, in combination with RVD, or they received RVD alone for 3 6-week cycles. Patients then underwent autologous stem cell transplant followed by maintenance with either ISA, Lendex, or Lendex, interestingly. So that's slightly different, the dexamethasone dosing. That's not something that a lot of us commonly use in the United States, but so it's a very similar study designed to the GRIFFIN study, except for instead of daratumumab, it's isatuximab. What were the results? As we might have come to expect with the data thus far, very similar rates actually of MRD negativity, except for this was at the end of induction. 50% of patients who were valuable were MRD negative with ISA RVD, versus only 35.6% who were MRD negative who got RVD. And we see the same trend with respect to response rates at the end of induction. So our next polling question, in the GMMG HD7 trial, the monoclonal antibody isatuximab was added to which one of the following backbones? A, VTD, B, KRD, C, RVD, or D, VCD? I'll let you guys answer. All right, great. Well, I'm going to pass it off again to Dr. Shah. Thank you all very much. For those of you who chose RVD, that was the right answer.
Great. Thanks, Andrew. So now we're going to turn to updates in transplant-eligible, newly diagnosed multiple myeloma and talk about the role of consolidation in tandem transplant. One of my most favorite transplant trials is the BMT-CTN 0702, where newly diagnosed patients had induction choice, dealer's choice induction chemotherapy, then went on to transplant and were randomized to get only maintenance, 4 cycles of consolidation and then maintenance, or a tandem transplant and then maintenance therapy. And this was really to answer, can we do more besides just maintenance therapy after transplant? As you can see, these actually turned out to be it was a negative trial, but in a positive way, because now we know that giving maintenance therapy is enough for all patients that were randomized in the intention to treat analysis. And there was no difference in the 3 arms between for PFS or overall survival. And what's interesting about this, though, is that there was a long-term follow-up analysis, which was presented several years ago. Now, what happened? We talked about indefinite len, and I think this really drives home the point that I was saying before, that that giving lenalidomide maintenance therapy for as long as you can is better. And you can see the people who had the option to drop off on the len, because at the time that the trial was designed, we did not know that. And so patients were allowed to come off len if they wanted to, and many of them stayed on. And you can see a clear drop off for those patients who stopped the lenalidomide versus those who continued lenalidomide, which again suggests that, and we get little pieces of information from each of these trials. And for me, this suggests that the indefinite lenalidomide is the way to go. So now, if you look at the EMN02 H095 trial, this is a little bit different because these patients received induction therapy with bortezomib, cyclophosphamide, dex, which I consider to be more like a 2009 regimen, not really so much a 2022 regimen, but whatever, be that as it may, they were then randomized to receive VMP or transplant. And if they had a single center or an ability to give tandem transplant, they got a tandem transplant. And if they had the ability to only give single transplant, those patients got double transplant. And then there was a second randomization to consolidation versus no consolidation. So a little complicated and not completely random because some patients went on to 2 transplants versus not because of center availability. So what happened here, as you can see, the progression-free survival did favor getting VRD versus no consolidation in that secondary randomization. I think although this is positive, I feel it's hard to interpret in the setting of having so many novel regimens, which, as I already talked about in the beginning, VRD is the category 1 and DARA VRD is catching up. So I'm not sure that this is pertinent to the current practice setting, but I think it does suggest that there can be things done after transplant if you want. And in this case, also the tandem transplant for those who got it. Now, remember, it wasn't totally random because it was dependent on the center preference. Those patients who got a tandem transplant actually had an improved PFS. And in a follow-up as subsequent ASH data, they actually had improved overall survival. And I think what this means to me is if you get really good therapy up front, then you're likely going to do better. But if you don't get really good therapy in induction, then the way to get there might be to do more after the transplant, whether it's by a second tandem transplant or including consolidation therapy. But we have such good induction therapies now. I would caution applying this data to our data for RVD or DARA RVD because we're doing such good jobs at getting people at MRD negativity even before or right after the transplant and before maintenance therapy. So just a word of caution, but it's another piece of data that, again, this theme in myeloma, more is better. And I think this is what this tells us, depending on when you get to that more. Okay, so the polling question, which one of the following was reported in the Stamina trial? Secondary malignancies occurred with high frequency in lenalidomide treatment arm. Hematologic malignancies occurred with high frequency in the lenalidomide treatment arm. Solid tumors occurred with high frequency in the lenalidomide treatment arm, or secondary malignancies were not significantly different in the 3 arms. And I'm sorry because I didn't go into the secondary malignancy data, but let's see how we get, and I'll tell you the answer. So the answer is that there were no differences in this particular trial, although in the original lenalidomide maintenance trials, there was a difference between the len patients and the patients who did not get len in secondary malignancies. But it didn't really matter for this particular trial where you got randomized, and all the patients did basically similar, which is pretty reassuring in the sense that what you want to choose for the patient, you can choose based on the PFS data alone. Okay, moving on.
All right.
We're going to, I think, Andrew, you're part of this one, right?
Yeah, I'm going to take over for this, and I think you're going to do the next section. So,
great.
All right. So, I'm going to be talking a little bit about updates in transplant ineligible newly diagnosed multiple myeloma, which, one common question is who is the transplant ineligible patient? And I think that's often something of debate, because many times, we're often told that age is just a number and that, 80 is the new 50 or whatever, phrase people are using. But, in general, age is associated with increased burden of comorbidities. There are fit 80-year-olds who run marathons, but for the most part, that's not the norm. Many, as we get older, there are more comorbidities. People become more frail. Patients are less able to tolerate intensive therapy. And so that is the reason we have these great studies that are conducted in patients who are quote unquote transplant ineligible, because I think, multiple myeloma is in general, it's a disease of older Americans. And so many patients, and I'm somewhat of an outlier. I practice at a transplant center. It's a tertiary referral center. So we're enriched for the transplant eligible patients, but in the community, that's going to be much different. With that, let's dive into some of the data. So here's the current status of the recommended regimens from the NCCN guidelines for transplant ineligible newly diagnosed multiple myeloma. Preferred regimens include RVD, which we're familiar with from the transplant eligible setting. In many oncologists will utilize once weekly Velcade or sort of that RVD light for the transplant ineligible populations, which, some data suggests may have lower rates of neuropathy. I think one thing for certain is patients are in the infusion center less because they're only coming in once a week versus twice a week, which, everyone's going to be happy about. Dara-Lindex is another regimen that has been studied, and we'll review some of the data for that. Other recommended regimens include KRD, Dara-VMP or bortezomib melphalan-prednisone, ixazomib, lenalidomide, dexamethasone. Remember, ixazomib is the oral proteasome inhibitor, and daratumumab, Cytoxan, bortezomib, dexamethasone. In certain circumstances, we can use Lendex, and then, like I mentioned, they mentioned that it's useful in certain circumstances for RVD light, but I think many of us, for patients who are transplant eligible, will use that in most patients, at least in my practice. Let's start with some of the data for upfront newly diagnosed transplant eligible. So the ALCYONE trial is shown here, and I think this study has sort of, limited generalizability in the United States. The backbone of this study was VMP, bortezomib, melphalan, and prednisone. That's not a regimen that many use in the United States, but it is commonly used in Europe and likely in other countries. And so I think from a sort of global perspective, this is a good study. So patients received daratumumab plus VMP versus VMP alone. The study, as we've seen with the addition of monoclonal antibodies to the upfront setting in other scenarios, we see improvement in progression-free survival, and also improvement in overall survival. And so these data these were some of the first data that were presented that showed the benefit of daratumumab in the transplant ineligible population, but again, sort of limited application in the United States. The MAIA study, I think, is much more useful for us in the United States. The study was designed for patients who are transplant ineligible. Patients received either Dara-Lendex or Lendex. So the comparator arm, Lendex, was for many years a very common regimen used for newly diagnosed transplant ineligible multiple myeloma. The study, showed improvement in progression-free survival, and I think the results from the study are really pretty amazing. At a median follow-up of 56 months, the median PFS was not reached in the daratumumab group versus only 34 months in the control group. Median overall survival is not reached in either group, and we have a PFS rate in the Dara arm of 60%, which is pretty amazing for in large part an older, more frail population. So our next polling question: based on the data from the ALCYONE trial, which of the following is true for transplant ineligible newly diagnosed multiple myeloma? A, daratumumab, lenalidomide, dexamethasone was associated with improved PFS as compared to Lendex. B, daratumumab plus RVD was improved with PFS as compared to VRD. C, daratumumab VMP was associated with improved PFS as compared with VMP. Or D, dara-KRD was improved with PFS as compared with KRD. So let's go ahead and answer those. All right, terrific. So for those of you who chose C, that is the correct answer. Dara-RVD, the results of that have not been published yet. And yes, Dara-RD is associated with improved PFS, but that was not the ALCYONE trial, that was the MAIA study. All right, well, I'm going to wrap up with this section. Now we're going to jump into the cases. Dr. Shah, do you want to go ahead?
Thank you. So we're going to have an interactive case study, and we'll try to go through this a little quickly. We're running a little short on time. This is a transplant-eligible patient who presents with a high creatinine of 1.8, and further testing shows kappa-Benz-Jones proteinuria. The patient has a hematocrit of 45, albumin of 4.4, platelets of 177, has a kappa of 1119.7 with a ratio of 133, beta 2 slightly elevated at 4.2, but LDH is normal. IgG is 431, and IgA is also low. IgM is low. The patient has hypertension, proteinuria, but is essentially looking like has light chain multiple myeloma, as you can see here. Bone marrow biopsy has 20% involvement with kappa restricted cells, and the FISH is positive for 1114. Cytogenetics are otherwise normal, and the PET is negative. So the patient is diagnosed with kappa light chain RISS stage 2 multiple myeloma. And in this case, you can see that both due to the renal issues and also due to the light chain ratio, which is above 100, this patient would be considered symptomatic multiple myeloma and require treatment. Now, you know that the patient already has a history of hypertension, now has proteinuria, high creatinine, and definitely elevated serum-free light chains. Due to concern for myeloma cast nephropathy, the patient received cycle 1 of bortezomib, cyclophosphamide, and dexamethasone. And Andrew, this is one of those things where you wish you could give your RBD, right? But it gets to be a little bit tough with the creatinine kind of on the rise. And have you had this patient situation before?
Yes. I mean, I think it comes down to the time it takes to get lenalidomide approved, which can be like a week, and we can give VCD in the hospital really quickly. We can do it the same day. And so it's really, for me, it's more of like a timing issue. It's not that we can't give lenalidomide with impaired renal function. It's like getting the drug into the patient. I mean,
right. Yeah, I agree. I don't know why this exists, where like oral chemotherapy is like the hardest thing to get, but it's true. And it does. It's like we can put a man on the moon, but we can't do that. So, but it does happen that sometimes you need to get quick tumor reduction. And for someone who's 40 who really could save his kidneys, this is somebody you want to give aggressive therapy to. And I would agree with this particular approach of giving bortezomib, which you can get in house many times. Cyclophosphamide also very easy. And for some people, you might even give a high dose of cyclophosphamide, really pushing them because you want to make sure that you can save those kidneys from turning from that 1.8 higher and really turn it around as much as you can. So I agree with this as well. So which induction regimen would you choose aside from what we talked about after the patient gets discharged and is doing better? Which induction regimen would you choose for this patient? You can use RVD, KRD, DARA-RVD, or VCD, or other. Great. Okay, so just, we see a nice division here between RVD and DARA-RVD. Andrew, what would you do in this situation?
I would give DARA-RVD.
Yeah, I think I've kind of switched over to that as well because it does have, I think it's pushing over into that PFS benefit. And we're going to see from the Perseus trial the final results, but that's probably what I would do once the patient is out of the hospital. And we know that patients can get in very deep stringent CRs and MRD negativity, as well as sustained MRD negativity with this regimen. Okay, so I'm going to hand it over to you for the next case.
All right, our next case is an 80-year-old woman who presents with back pain, and a plain film of her lumbar region shows lytic lesions in L3 and L4. Further testing, I'll just summarize quickly. She's anemic with a hemoglobin of 8.1. She's got a 3.4 gram per deciliter monoclonal protein. Serum-free light chains are slightly abnormal with a ratio of 23.6 of involved to uninvolved. She's got lambda-Benz-Jones protein, beta-2 microglobulins 5.6. LDH is within the normal range. Past medical history is notable for diastolic CHF. She's on Lasix, but the echo showed increased filling pressures. The bone marrow biopsy was performed, showed 40% kappa-restricted plasma cells flow, confirmed a lambda-restricted plasmacytoid neoplasm. FISH were performed and showed a translocation 414 and a 1Q duplication. No information on copy numbers of the 1Q, which is something we sometimes look at. Cytogenetics did show a complex karyotype. Osseous survey showed lytic lesions, and a PET-CT showed abnormal uptake. So, basically we've confirmed the diagnosis. The patient has multiple disease-related diagnostic criteria, the anemia, the lytic lesions, the 40% plasma cells. And so she's got high risk chromosomal changes. Remember the translocation 414, we didn't talk about this, but the high risk chromosomal changes the classic ones are the ones that are looked at by the IMW as high risk, are the deletion 17p, translocation 414, translocation 1416. Some of the other ones that are sometimes included are the 1Q amplification and also the translocation 1420 and the presence of complex karyotype by conventional cytogenetics. So which of the following induction regimens would you choose for this patient? A, RVD, B, KRD, C, daratumumab Lendex, D, ixazomib Lendex, or E, other. So go ahead and choose your answer. All right, kind of an interesting split, kind of actually what I was expecting. About half of you chose bortezomib, lenalidomide, dexamethasone, actually 20%, and 80% chose Dara Lendex. I mean, Dr. Shah, what are your thoughts on this? I have my own opinions on this, but high-risk patient, transplant ineligible, diastolic CHF, and what would you?
Yeah, although the high risk from the 414 is there, and we think that proteasome inhibitors are better in this category, we actually don't know that for sure. But we do know that patients get DARA RD and transplant ineligible do better than RD. And I think for this 80-year-old patient, I would have chosen DARA RD. This is one of those complicated patient situations because it's just, if it's transplant ineligible straight up, then DARA RD is what I would do. But with this complicating high risk feature, there's a question: do you need that proteasome inhibitor? I think I would still go with DARA RD to start, see how they're doing. And then if things aren't getting better, maybe add that fourth drug in, but understanding that maybe the patient has an okay 414, not a bad one, and may be able to have a nice duration of response at age 80 with DARA RD alone.
Yeah, I think you've highlighted that, this is an area where there's lots of opinions, but, the data is, we have the HOVON 65 trial that showed improved outcomes with proteasome inhibitors post-transplant in high-risk patients, which I think, for large part, has been the basis for the recommendations that high-risk patients get proteasome inhibitors. Correct me if I'm wrong, but I think that's part of where that comes from. But, that kind of analysis has not necessarily been sort of repeated and shown to be consistently true. So I personally probably would have gone with RVD, but because of that, but I don't think it's wrong. I think DARA Lendex is a reasonable choice too. It's certainly, there's no neuropathy, right? So yeah,
that's one of those things. We're kind of at the top of the hour, and I want to make sure I answered some questions, and I'm just going to go through rapid fire. There's a question about progression-free survival for the IFM. Sorry, for issues with transplant, and about quality of life. And I would really actually point out that quality of life, although it drops in that first 2 weeks around transplant, an analysis was recently published by the CIBMTR, which showed that the quality of life returns to normal very soon after that, within 3 months. And so I think that I'm okay with that drop in quality of life just during the transplant, but other people may not agree. Andrew, do you agree?
It's transient. It's like any high dose chemo. There's like 2 to 3 weeks of recovery. And so I think, as long as people are informed of that, as long as patients are informed of that, I think, and they know that they're going to get, it's not permanent. It's temporary. So, I agree.
And then there's a question of what circumstances to use a monoclonal antibody-based quad regimen and newly diagnosed. And actually, I think that for my standard risk patients, I've basically adopted DARA RVD as upfront therapy. If I have high-risk patients, I've tended to use KRD based on the FORTE sub-analysis, which we didn't get into today. But I think almost all patients, if you think they can tolerate a quad, should get a quad for newly diagnosed standard risk. But what do you think, Andrew?
I was somewhat of a slow adopter in this regard. I was like, well, the PFS, is it going to get there? I think I'm increasingly convinced, given the MRD data. And so I really sort of, at this time, largely moved to that approach as well.
Great. And I think we're about ready to close up the webinar. All right. Have a great day, everybody. Thanks.
All right.